From the RSNA, this is the Radiology Artificial Intelligence Podcast. My name is Paul Gee, and I'm a radiologist at the University of Maryland and co-host of the podcast.
And my name is Tejani, and I'm a radiology resident at the University of Texas Southwestern Medical Center and co-host of the podcast. Each month, we dive into the hottest topics in radiology AI and talk with leading experts, thought leaders, and movers and shakers in the field.
And we're back with the Radiology AI Podcast. We're joined by two of the authors of a recent publication on automating myelin maturation on pediatric MRI scans. Learn more about the team's approach to this clinical use case, dataset, and future plans.
Akincidantonoli is currently a radiology resident at the Continental Hospital Basel and a researcher at the University of Basel, Switzerland. Her research interests include deep learning and radiomics applications in neuroradiology and cardiothoracic radiology. She was recently awarded with the Andres Gideon Award by the Swiss Society of Pediatric Radiology. Tugba is also a member of the journal's trainee editorial board and member of the Young Club Committee of the European Society of Medical Imaging Informatics. Jakob Wasserthal is a research scientist at the University Hospital Basel. After studying computer science and co-founding a successful software startup, he completed his PhD in medical image analysis, focusing on brain connectivity in diffusion MRI. He is the creator of Total Segmentator, an open-source toolkit which enables automatic segmentation of all major anatomical structures in CT images.
Tugba and Jakob, thank you so much for joining us here for another episode of the Radiology Artificial Intelligence Podcast. It's a real delight to have you here to talk about your work and most recently this article that was published in Radiology AI. So just for our listeners who might not be familiar with pediatric radiology or pediatric neuroradiology, can you tell us about this clinical problem of myelin maturation for those of us who aren't familiar?
Sure. First of all, thank you for the invitation, and I'm delighted to be here today. The clinical problem we tried to address in this study was the estimation of myelin maturation from pediatric brain MRIs. In day-to-day practice, assessing myelin maturation is crucial for detecting and treating developmental disorders. However, this assessment process is complex and requiring expertise and prone to variability between and within observers. And you might have heard the often quoted saying in pediatric radiology or pediatrics in general is that children are not small adults. I guess I didn't appreciate the profound meaning of this saying until I began my fellowship in pediatric radiology. And children are in a constant process of growth. Beside having a whole range of disorders, they exhibit different imaging characteristics across different ages or different months, even. And this is particularly evident in brain MRIs. And at the core of this clinical challenge lies the rapid progression of brain myelination. And normally, myelination begins around the 25th of week of gestation. A term newborn exhibits limited myelin in certain locations, such as the posterior limb of the internal capsule and the perirolanthic white matter. And this will change rapidly by the first year. Brain will have almost an adult-like signal intensity in T1 weighted images. Yet only by the second year, brain will manifest an adult-like signal intensity in T2 weighted images, meaning that even the developmental milestones would differ between T1 and T2 weighted sequences. And between the second and the third year of life, only terminal myelination zones will be observed, which is located predominantly in peritoneal areas. And as you can imagine, navigating this ever-changing landscape is quite challenging, not only for residents and fellows like me, but also for experienced pediatric radiologists. And this was the personal challenge and also the main motivation behind this study. And therefore, we developed a model to support decision making in the interpretation of myelin development.
Thank you. No, this is definitely a complex task, and it really helps to have that context, especially for those of us that may not be working with it on a day-to-day basis. And I love how we have personal experience and your expertise in pediatric radiology to help guide us through this. So trying to think of the workflow. This isn't an easy workflow. Is that fair? And maybe you can help us understand the specific task and efficiencies that inspired the solution. If you could help me understand in that answer, how long it normally takes to manually perform that task.
Yeah, sure. And in the clinic, we often use standard developmental charts and atlases to assess myelin development. And this process similar to assessment of bone age. And I know many centers have now automated bone age evaluation, but some listeners may remember a few years ago, the manual method involved comparing the patient's radiograph to images from Grolich and Pyle bone age atlas, and assessing the bone age manually might be also challenging because development of the carpal bones might correspond to certain age, while the epiphysis of the phalanges might correspond to another age. So in the end, one may have to guesstimate the overall bone age. So similarly, myelin development at one location could correspond to a certain age and another age at another location. So this traditional approach, either for determining bone age or myelin age, can be time consuming and is susceptible to inter-observer variability. Also, in routine practice, we tend to make only a statement about whether myelin maturation is age appropriate or not. And it is more of a global assessment, and our focus is not just on myelin maturation, but on global brain maturation. And only if there is an explicit clinical question or suspicion about developmental delay, we tend to assess myelin maturation in detail and define corresponding myelin age. At least this was what we do in our center, and this whole process might take less time if the child is completely normal, and then the assessment of maturation would be also quite simple. Let's say it would take no longer than reading a normal brain scan. However, most of the time this is not the case, and there are complex cases where the patient has some disorders or tumor, which makes it difficult to assess the underlying myelin, even the child has reached the age appropriate milestones. And as you can imagine, this assessment of myelin age in such cases is not easy and might take longer and be more prone to inter-observer variability.
Yeah, I think that's super interesting. This idea of automating these kind of baseline tasks that we have to do as radiologists, right? Even before we diagnose an image, we've got to figure out what's normal. Is this appropriate for age? I'm still haunted by the pediatric elbow x-rays that I still have to read on occasion, figuring out the ossification centers. But then when we think about myelin, that's, to me, it's like a foreign language. I think it's really just commendable what you all have done. So I'd imagine that compared to bone age, which is relatively more straightforward, it's a 2D X-ray, pretty standard. What were some of the challenges you faced in curating this data set? I can imagine there's challenges, one, in just finding the normal cases, as you said, but two, maybe dealing with just the larger number of images, the 3D nature of it. And then one other thought, I'd be curious, is what are the considerations for establishing ground truth? I don't know if these things have been shown to differ between different populations, and it is a little bit of a uh, chicken and the egg kind of problem. Do we use an atlas that's based off of small sample sizes? Do we use some other ground truth? So I'd love to hear any thoughts of any of the above.
Sure. So we have retrieved brain MRIs from our archive, and for the last 10 years, actually. And the earliest date we were able to access was 2011, because in 2011 the hospital moved to a different building and the system was changed. And so we included images of normal infants and young children of 3 years of up to 3 years of age, and normal, of course, in terms of myelin maturation. To maintain a data set reflective to real life situations, we included images with minor motion artifacts as well as subjects with pathologies unrelated to myelination disorders. And we excluded the external images or follow up studies from a same patient. The images distorted due to severe motion artifacts or patients with pathologies covering entire brain. And of course, coming to your question about ground truth, the main challenge was while creating this data set was we needed to go through all cases one by one and check the images to apply this exclusion criteria. So we labeled all the data, but these were actually text-based labels, and this was done by referring the standard myelin development charts or atlases, and also in the training sets we refer to patients' records or follow-up images to determine normality. And the complex cases, all complex cases, also reviewed together with pediatric neuroradiologists.
I can now also say a little bit more about those additional external data sets which we used for our external validation. And there, yeah, it was difficult to find some, but we managed to find two which we could actually use. And one is from the Developing Human Connectome project. So I think a lot of people know this Human Connectome project with those very high resolution adult images, and they have also a project for for children. And there's where we got quite a bit of data. And the other one is actually from the National Institute of Health Pediatric Brain MRI database. And yeah, so this NIH, we call it NIH test set, that was also really helpful, especially for having also a bit older children, because developing human connectome project, that's really mainly quite newborn babies. Yeah, so that's kind of the two sets which we used. Yeah, accessing the developing human connectome project was quite easy. That was nice, but getting the NIH data set, that was a real pain. So that, I guess, took us a few weeks in the end, a lot of hours, and so that's really a pain. And in the future, I really hope that people make it easier to access those data sets, because it's just so much research time wasted for paperwork, basically. Yeah, but in the end, we managed to get it. In between, we were not sure anymore if we will manage, but it worked out. And those are basically the two data sets which we used.
So I forgot to add, actually, the bottleneck of our project was data labeling, and it took maybe more than 1 year, and it was really difficult going through those all those cases.
Yeah, thanks for sharing all that. I think that one thing I think sometimes people don't realize is just how much blood, sweat, and tears, figuratively or maybe in reality, that goes into a project. It's everything from signing data use agreements, running them through the administration, both internally and externally, and like you said, labeling the images. So really, kudos to you for persevering, and I think it's a tremendous accomplishment.
I'm just excited to hear that we're making headway in this space as well, for the reasons that Paul mentioned. And you think about even for adult patients trying to facilitate external validation on external data sets, that itself is difficult. All the considerations that you have to take into account for pediatric patients, especially, it's a little more sensitive depending on where you're practicing in terms of accessing that data. And Jakob, just really your point of how hard it can be to access some of our external data sets really resonates. And I'm glad to hear that both of you and your team overcame that challenge. Building off of our data sets here, going more into the results, without giving too many spoiler alerts to our audience, definitely read the paper, please. But we're going to talk just briefly about one of the findings. It looks like the mean absolute error between the two external data sets was a little different. Do you think that can be attributed to the age range differences between both the data sets, or are there any other factors that should be taken into consideration?
Yeah, so it's pretty much due to the difference in age range. So the mean absolute error for our developing human connectome project data set was 0.3 months. So it was a really, really small error. And in contrast to that, for the NIH data set, it was a lot higher with 1.2 months. And this really comes down to the difference in age range in these data sets, because for older subjects, it gets more difficult to estimate the age precisely. And yeah, this makes basically all the difference. So that the developing human connectome project datasets, it contains only infants younger than 2 months. And yeah, for the NIH dataset, we have children up to 25 months of age. And for those older ages, we typically also get larger errors, which you can imagine even as a doctor, if you look at it for a 2-year-old child, it's hard to tell exactly by a week for, let's say, below 1 month of what age it is. So that's more difficult. That's the main difference, I would say.
I would like to add that our model provides clinically relevant results given that severity of myelin maturation delay depends on the age of the patient. In the first 12 months, myelin maturation accelerates at a very rapid pace, and after 2 years of age, it slows down. And if the patient is very young, for example, if it is a newborn or 2 months old, then even 2 months of delay would be quite noticeable. Whereas if the patient is older than 2 years, even a delay greater than 2 months could be very difficult to notice. For this reason, model predictions had also more variance with the increasing age because there are fewer visual changes associated with myelin maturation and making it quite difficult even for experts to determine age from images, and model for performance clearly reflects this clinical challenge.
Yeah, I think that's such an astute point that, oftentimes we can get so honed in on what's the mean absolute error, what's our AUROC, et cetera. But, I always tell students and trainees in my lab that statistical significance is one thing, but clinical significance is a totally different one, right? And I think it's really important that these results get contextualized and how does this actually impact? Is this meaningful? And so in light of that, how do you see the solution changing standard practice? Do you see it being translated in the near future, or is this something that still needs to be validated? What are your hopes and dreams for this? Because this is obviously a very exciting path, and I'm guessing this isn't the last that we're going to see from the group in this space.
So I think our model will provide an accurate estimation of myelin age, and this will allow us to detect white matter disorders early. And more importantly, our model will help trainees and general radiologists determine the normality of myelin maturation. So as you know, there are large group of leukodystrophies, namely white matter disorders, that might be quite difficult to detect in early stages. And our model may facilitate early detection of these disorders. And currently, we do not have enough data to test this hypothesis, but we are open to collaboration specifically on this topic. And if you have a large data set of patients with leukodystrophies, please get in touch.
So, speaking of getting in touch, have you heard from readers or anybody else locally or internationally who's tried using the solution? And if so, what were their thoughts?
Yeah, so we have our model on GitHub. So basically, anybody can download it and use it. But so far, we haven't heard of anybody. But well, typically most people who use it don't tell you; they just use it. So it's hard to know who downloaded it and actually used it. And what we actually know from our data set, that's actually been that we can see some statistics, and it's been downloaded by over 100 people. So apparently, quite a few people find that useful. And I think because it's actually the largest data set publicly available for this kind of images. I can imagine that quite a few people find it really useful. Also, especially because we try to avoid all the pain with paperwork and so on. So it's really easily available. You just click on the link and then you click on download, and no paperwork and annoying stuff needed. Yeah, and apart from that, we are also planning to implement it basically in our clinical routine. This has not happened so far. We're also currently changing our PACS provider, and that's of course introducing difficulties. And we've also been in contact with a children's hospital in UK who have been interested in that, but also this because of data sharing limitations and so on, that has been more difficult actually to collaborate there.
Well, if you're listening and you heard what Jakob said, please reach out, right? For collaborations, always love to see that clinical translation. And if you're using the tool, let us know too, right? What do you think?
Yeah.
And so as we wrap up here, any final thoughts that you'd like our audience to take away from this conversation?
So I would like to also mention that during this study, we made an interesting observation. We observed that there is a range of normality for myelin maturation, and that is approximately 1 month, at least for our dataset. And as you know, in developmental pediatrics, percentiles are used to evaluate normality of height or weight progressions, which based on standard growth charts. And typically, individuals falling below the third or above the 97th percentile are considered outside of the normal range. And however, when it comes to mild maturation, there is no established range of normality. But in this study, we notice there are individual differences. And therefore, we considered a myelin age within 1 month of chronological age to be within the normal range. And I think we need larger population studies to determine this range of normality. And that was an unexpected finding that we gained from this study. And right now we have a master's student and a student working on it, but mainly from a neuropediatrics perspective. And to determine range of normality, she is comparing our results to the results of neurodevelopmental assessment tests like Griffith or Bailey scales, which assess motor, cognitive, and language skills in infants and young children. And her study is dealing with the same data set as we as well, but I think it would be great if we had more data and studied a larger population to investigate this issue further.
Yeah, I totally agree with Tugba. So I guess in the future it would be great to have access to more data and more people sharing their data. And there in the literature, there are similar papers to ours who have done similar stuff in the past, but they did not share their data. And we thought it would be so nice if we had their data set, and that would also improve our study a lot, of course. And so we hope that in the future, more and more people will start sharing it.
Well, I think that's a perfect message to end on here. Hopefully, we can have more data sharing and more data sets to work with in the future, especially when it comes to pediatric AI. Tuva and Jakob, thank you for joining us.
Thanks for having us.
And we will see you all next time on the Radiology AI Podcast.
Thanks for joining us for this episode.
Subscribe for the Radiology AI Podcast for more discussion on content from the journal and hot topics in our field.
We hope that you've enjoyed this episode of the Radiology Artificial Intelligence Podcast. Shout out to Uriah Shemchisen for our podcast music and to the RSNA podcast staff.
Email us at podcasts@rsna.org anytime with questions, feedback, or suggestions.